I'm Kieran Anderson, group publisher here at Applied Radiology. I'm today joined by Professor Mathias Prokop, who is the chairman of medical imaging at Radboud University in Nijmegen, the Netherlands. Dr. Prokop, so good to have you sitting down with us.
Thank you so much. It's a pleasure.
I know that you've just come out of a lunch and learn session that was sponsored by Canon, and you actually had quite a panel with you. Let's talk about sort of the cross-specialty highlights, something that was talked about. As moderator, you had a really unique sort of vantage point across these sort of diverse presentations that were given by your colleagues on the panel. Maybe ask you, what stood out to you as one of the most significant advancements shared today across sort of lung and vascular, and when you're thinking about these multi-system imaging systems and applications, particularly in CT?
If you look at what CT has done in the past, it was morphologic imaging. And actually, at the moment, it still is. What two of the talks today did is they showed that you can still push the limit. And when it comes to image quality in photon counting CT, but also with peak in regular CT, the limits have been pushed quite a bit towards really very, very fine detail, which we couldn't do beforehand. The other thing is that the image quality becomes more constant, especially for cardiac. And the reason was motion artifacts and not enough resolution. So when you had a high degree stenosis or a stent graft, didn't really work too well. Now, with the new technology, this is all solved. Metal artifacts, motion, and ultra-high resolution all in one, which makes cardiac CT, should I say that, idiot-proof? No, but basically it requires no longer this very dedicated specific attention to preparing the patient in the right way. It makes it much more stable in the clinical routine. That was a really important one. And the final thing, the upright CT scanner actually allows us to do stuff that we couldn't do before, namely looking at weight-bearing joints, knees, for example, the feet, but also the spinal column, how that changes, the abdomen. So there are lots of functional activities that we are now able to image and analyze and ultimately diagnose. So it moves from CT being mainly something interesting for vascular or oncologic applications to something that becomes also interesting for chronic disease. And I think this scanner is exquisitely useful for this area.
And I mean, you heard from a number of different people, and you talked about, in a way, making it something that you use the word idiot-proof, but the reality is that it's doing most of the work and it's making life easier. So that's affecting the way the technologists work. It's just making life a little bit easier, probably more efficient in your CT department.
Absolutely. And of course, we don't have idiots that work there. We have highly skilled people. But what we now have, cases in which they do their best and still it doesn't really work too well.
Right.
This is, with this new technology, virtually gone. This means that we get excellent, consistent quality, independent of whether there's metal in the patient. One of the big problems was always metal in pacemaker leads. That would kind of completely kill imaging of the right coronary artery. Gone. Valve leaflets, nicely available now. So I think it's really a big step forward. And the other thing is temporal resolution. Now with these virtual ways of doing it, you can bring down the temporal resolution way lower than you ever could do with dual source, triple source, quadruple source. It's basically now bringing it down to roughly 14 milliseconds, which is gigantically low.
One of your presenters, Professor Remy Jardin, I believe, presented some exciting applications as it relates to photon counting CT, particularly in high-resolution lung imaging. From your perspective, Doctor, how transformative do you feel photon counting CT is, and certainly, will prove to be in sort of thoracic diagnosis today, and where do you expect the next breakthroughs?
Yeah. Now, what you see is that CT, of course, has evolved over 50 years, and it's doing a terrific job for most of our routine applications. It solves the clinical question. But there are some areas where really doubt remains, and one of these areas is classifying interstitial lung disease into really fibrotic or progressive fibrotic, and that will ultimately decide whether you give these patients expensive treatment or not. And you would like to be early so that you actually can prolong their lifespan, but you would not like to expose them to the side effects if it's not really necessary. And that really, with this ultra-high resolution scanner, you can see really very, very small traction bronchiectasis in these areas of fibrosis. You can see reticulation that would be ground glass or just a little bit irregularity in the lung parenchyma where I didn't know was it noise or real stuff. And it has to do with this combination of high spatial resolution and low image noise. Because as I just mentioned, if you have these noise granules that are suddenly darker, lighter, super difficult to say whether something is really a bronchiectasis or just noise. Now, especially also with higher image matrices that come with this ultra-high resolution CT, that becomes way, way more consistent and easy.
When I asked you the first question about like what stood out to you, one of the things you talked about was the transformable CT platform. What is the benefit to like the clinician in the real world practice? What does it mean for the patient?
There are a couple of aspects. The fact that it's a transformative systems means that you can make it economically viable even if you don't have enough patients that need to go into upright CT. That's one thing. When it comes to high throughput CT screening, for example, that happens now in many European countries. In the US, we know that there are still some problems. But if you really have a lot of patients that would be able to come one after the other, it takes just 1 minute for someone to get in, get scanned, get out of the room, which means the amount of throughput you can generate is just gigantic, which means that the effective cost for this exam as such is going down into minuscule amounts. So it's really, really a groundbreaking change for high throughput scanning. But that's probably not what most people will be excited about. I am, because I do think that we should bring screening to the masses in a way that is financeable. But the areas where we can help patients get diagnoses that they otherwise would not get is, I think, in the region of pelvic floor instability. We now do that with MR and we do that with pressing. But we never know whether the amount of change we see is the realistic change that they encounter in everyday life. If you do that in an upright scanner, and a CT like the one that we're talking about can do that fantastically. You can see these pelvic floor instabilities in exquisite detail and especially see what the real extent of it is. And we're sometimes surprised how much more it is than was originally thought about. Now, the other area where we have a limited experience in upright MR, which used to be there, is looking at joints, where we know when we have these early stages of arthrosis, of osteoarthritis, you frequently on X-ray see nothing, or very, very little. If you kind of put patients upright into such a scanner, you see suddenly changes that appear in these patients. It can be a change in the thickness of the cartilage layer. It could be a change in the rotation of the joint. So all the things that we actually don't really know too well because we couldn't examine it are now open for investigation. And we have a couple of things that are obvious, like the ones that I just mentioned. But there are probably many, many more that we are playing around. And Professor Jinzaki had shown a couple of really experimental things, looking, for example, at voiding CT, or look for a patient with urethral stenosis, or looking at swallowing CTs. So there are applications that we probably have not yet on our radar.
Haven't discovered yet. I'd like to switch topics here and talk a little bit about elevating image quality. I know that there are some new features, new technologies that certainly Canon has brought into play with this new scanner. Peak is one of them, also clear motion. So in terms of diagnostic confidence and sort of radiation management, as you think about it from those terms, how do these technologies change how radiologists can reliably, see? And what was most compelling to you, about the early results that you heard from Dr. Gassami's talk today?
Canon has pioneered in 2018 their precision scanner, which was the first ultra-high resolution CT with 0.25 millimeter slice thickness. Once you do that, you run into a lot of problems because suddenly there are way less photons on the detector. Image becomes extremely noisy, and not only high resolution, but they become also really, really noisy. So Canon, in optimizing the scanner, has developed technology which is now groundbreaking. This was improving the whole chain of acquisition of the images, but also of reconstruction. And for reconstruction, they went from model-based iterative reconstruction ultimately to deep learning reconstruction, which had helped us retain resolution and reduce noise to unprecedented levels. And with Peak, it kind of pushed it one step further. It actually restores resolution. It brings it to the maximum you can get out of a scanner, because usually we don't really display that. Now you can do that. You need a higher matrix, by the way. And that is now so helpful in many areas of the body. But it was a problem in the heart, because the heart is moving. Now, if I have a resolution of 0.2, 0.3 millimeters, this is minuscule. So when the heart is moving, just a little bit, the resolution is gone. So in order to get that going, they had to develop something else, which they call now clear motion, which is a software-based motion correction. First for the coronaries, but now also for all of the heart, which is an amazing feat. And that means that this virtual reconstruction brings down the spatial resolution, or brings up the temporal resolution down to what I just mentioned, 40 milliseconds. So together, it allows for exquisite and consistent imaging of the coronaries, even smaller coronaries, even highly stenosed coronaries. It allows you for better plaque imaging. It also allows you for better imaging of the perivascular tissue. So the density of that we know is a risk factor. So there are lots of options that suddenly open up. And because it's not only the coronaries, but the heart, we're now able to look at the dynamic imaging of the aortic valves much better. We're looking at the systolic and diastolic opening much better. So there are a lot of applications that suddenly become possible, simple. And I think this is one of the biggest breakthroughs here in this area for cardiac imaging.
As we sort of look forward, AI and intelligent imaging is definitely here to stay. It's not going anywhere. It's only going to get more embedded into what we're doing, into these CT systems, into how we manage our workflow and things of that nature. And the session that you moderated was really positioned around these intelligent technologies. We talked about Peak, we talked about clear motion, we talked about obviously, the scanner, the vertical and the horizontal side of things. After hearing the various perspectives that you heard from these, leaders in imaging who are all doing great work, what do you see as sort of the most important direction of CT, over the next 3 to 5 years?
I think one of the big new frontiers will be functional and dynamic imaging.
Yeah.
The problem there is if you take multiple images, you get multiple times the dose. So we're working together with Canon on techniques to reduce the dose for these multi-phase images so that the total dose becomes very, very reasonable within all the guidelines that we normally have. This allows us to look at function, perfusion, motion to a much better way than we could do now. So most of that is image processing, AI, and clever use of the information that is in these images. And that, I think, will be one of the big frontiers for the next, say, 5 to 10 years. And of course, the technology we described and discussed will be further optimized, stabilized, made sure that everybody can do it, that they maybe can be transferred to lower end systems at one point. That will happen parallel. But the real cutting edge will come from clever integration of new multidimensional data and AI that will ultimately evaluate that. I have one last one, and that is something that I personally find also interesting. It's subtraction imaging, which is something that Canon has also developed, but not yet optimized. So it works. What they have optimized is really the registration so that you can do the subtractions. And the registration is very impressive. So that works fine. But the next step would be to use, again, image processing to reduce noise on these suppression images, which will give you something that is different from what we get from dual energy. Dual energy has these iodine maps, but they're not iodine maps, they're just soft tissue subtracted imaging. So in these maps, you see iodine, you see calcium, and you see every other metal that is in there. So it's not really an iodine map. But if you subtract, it is pure iodine. So I can see enhancement within the bones. I can see bone metastases which are not destroying the bone, but just infiltrating the bone marrow. And you can see the enhancement of the metastasis and not the soft tissue. So this is another area where I expect a lot. And one of the things that I'm personally very interested in, that black blood imaging for CT is around the corner using these type of technology. And again, that will hopefully transform cardiac and vascular imaging.
Well, then it certainly sounds like the future is bright for CT.
Absolutely.
And that, really that not only affects the clinicians and, you and your colleagues, but at the end of the day, this is all about patient care.
Exactly. And it helps us to be more secure in making diagnosis, confident, and also making sure that unnecessary exams and hopefully at one point also unnecessary treatments, which are those who do not have any effect, can be predicted and not be done. So that ultimately also our healthcare system profits for improvement in our technology.
Sounds very smart to me. Good stuff. Well, Dr. Prokop, thank you
You're
so
welcome.
much for your time. Appreciate it.